This question deals with a 56-year-old Caucasian male who was recently diagnosed with colon cancer, suffers from generalized edema. Urine protein excretion is 4.5 gram, so nephrotic syndrome, over 24 hours. Kidney biopsy shows glomerular capillary wall thickening. So this is the mother load here. Glomerular capillary wall thickening without an increase in cellularity. So cellularity doesn't increase. Without an increase in cellularity, kidney biopsy shows glomerular capillary wall thickening without an increase in cellularity. When the sample is stained with silver methanamine, irregular spikes protruding from the glomerular basement membrane are seen. So from the basement membrane, we're going to see irregular spikes. The patient most likely suffers from which of the following? So first of all, it's a nephrotic syndrome, and the nephrotic syndrome which has irregular spikes or spike and dome appearance is going to be Mgn. So getting to the answer for this particular question was not difficult. This is choice C. But still, let's take this opportunity to talk a little bit about Mgn. What is Mgn? Mgn is the second most common cause of nephrotic syndrome in adults, right? What's the first common cause? Focal segmental would be the first common cause. Up to 85% of Mgn cases are going to be idiopathic, okay? The remainder occur to a bunch of secondary reasons. For example, it can be caused due to systemic diseases. Systemic diseases, for example, diabetes mellitus, solid tumors from lung and colon, okay? Immunologic disorders, for example, SLE. So immunologic disorders, for example, SLE is going to cause this. So systemic diseases are diabetes mellitus, solid tumors, immunologic disorders. It can also be caused due to certain drugs. For example, gold, penicillamine, NSAIDs. This is also going to cause our Mgn. Third, we're going to have infections, hepatitis B, hepatitis C, malaria, syphilis. These kind of infections is also going to cause Mgn. Okay. Now let's talk about what we are going to see with Mgn on light microscopy, electron microscopy, and immunofluorescence. And let's compare that with Mpgn because there could be a little bit of problem understanding it. First of all, what I want to do is I want to draw a very bad looking glomerulus so that we have some sort of reference. So this is our glomerulus, and these are going to be our epithelial cells, let's say. These are our epithelial cells, and then let's say this blue thick region is going to be our basement membrane. So this is our basement membrane. So basement membrane, and then we are going to have our endothelial cells. So let's say this green region right here, let's say these are our endothelial cells. Let's say these are our mesangial cells, okay? These are our mesangial cells. So now we can talk about this. Now let's say on light microscopy, what are we going to see on light microscopy? We're going to see that there is going to be uniform, diffuse thickening of the glomerular capillary wall. So the capillary wall is going to be uniformly diffusely thick. It's going to be thick. Glomerular basement membrane thickening is going to happen. So on light microscopy, we're going to see thickening of GBM, glomerular basement membrane. What about electron microscopy? Electron microscopy is going to expand on the thickening, and we are going to start to see that there are deposits between the epithelial cells and the basement membrane. So this is our epithelial cell, the light blue. The dark blue is going to be our basement membrane. So we are going to see deposits right here. Okay, and these deposits are not uniform. I should not have drawn them uniformly. So you know what? I'm going to erase like some of it here, some of it here. So there's going to be deposits, but the deposits are not going to be uniform. And we're going to see it sub-epithelial, right? And these subepithelial deposits is going to resemble spike and dome. That's where the whole spike thing came from. They might not use the word spike. They might, tell you is pointy, anything. I mean, you have to understand how they could describe it. They might not necessarily say spike, but understand that it looks like spike and dome. So be aware how they could change the words, and you'd still have to be able to pick that up. So that's what we're going to see on electron microscopy. Keep in mind that we're talking about Mgn, not Mpgn. Now, what do we see on electrofluorescence? Now, see how these immunoglobulins deposited here, here, here. When we put it under electrofluorescence light, we're going to see, deposits here, deposits here, deposits here. So it's going to look granular. And the granular pattern is going to be due to deposition of IgG and C3. Where do we see uniform deposition? We see it in good pastures, because there the deposition is due to binding of the antibody against glomerular basement membrane. So that is our Mgn. I'm going to try to draw on this picture to see how the Mpgn might vary from the particular picture that we just drew. Okay, so for Mpgn on light microscopy, again we can see hypercellularity, but there is going to be a distinct difference between Mgn and Mpgn. With Mpgn, the deposits are going to be subendothelial. So deposits are going to be here, okay? Because the green area is our endothelium, so subendothelial deposits is going to happen with Mpgn. Some of the other things we're going to see with Mpgn is that on light microscopy, we're going to see thickening without hypercellularity, okay? So only thickening, but no hypercellularity. And there's another thing. There is type 1 Mpgn and type 2 Mpgn. For light microscopy, we usually see it in type 1, and type 1 is associated with hepatitis B and hepatitis C, right? We saw hepatitis B and C in Mgn as well. Here also we see hepatitis B and hepatitis C correlation. Okay, we're also going to see splitting of the basement membrane. So there's going to be splitting of the basement membrane. So the basement membrane here, there's going to be splitting of the basement membrane. This splitting of the basement membrane happens due to mesangial growth. See how light microscopy we said that is responsible for thickening with Mpgn? The thickening is caused by inner growth of the mesangial membrane. That's what we're going to see on light microscopy. What about electron microscopy? Electron microscopy is going to show the dense deposits. So these dense deposits are going to be seen on electron microscopy. And these dense deposits are usually due to C3 nephritic factor. Okay? So these dense deposits are due to C3 nephritic factor. So let's summarize. For Mpgn and Mgn, we're going to see both thickening of the basement membrane. With Mpgn, the deposits are going to be subepithelial. So with Mgn, the deposits are going to be subepithelial. For Mpgn, the deposits are going to be subendothelial. Okay. For Mgn, we're going to see spike and dome from the basement membrane. With Mpgn, we are going to see dense deposits. Okay. We're also going to see with Mpgn, we're also going to see splitting of the basement membrane due to mesangial growth. Now, the splitting of the basement membrane is also seen with Alport syndrome. Keep that in mind. It's on the side. It's seen in Alport syndrome as well. Now, Mgn is strictly nephrotic syndrome. Mpgn can be both nephritic and nephrotic syndrome. Okay. Now, Mpgn can give rise to diffuse proliferative glomerulonephritis, just like SLE can give rise to diffuse proliferative glomerulonephritis. Mpgn again can be both nephritic and nephrotic syndrome.